Here are my disclosures. So as has already been mentioned, patients pay a pretty high price for survival in prostate cancer in terms of the side effects of the treatment. And for hormonal therapy, there are the sexual side effects and there are additional side effects as well. I wanted to, for a moment, concentrate on the emotional volatility that can come with androgen deprivation and is genuinely experienced by patients, and they find it quite bewildering that they can become emotional, tearful, more vulnerable than what they were used to being when they did have testosterone under the hood, so to speak. We have learned that there is an association between androgen deprivation therapy receipt and depression, and that pre-existing depression can be really activated with androgen therapy, and that therefore it is very important to be attentive to that. The newer anti-androgens that are now employed in care quite often, ones that inhibit androgen synthesis and ones that inhibit androgen receptors, have even a stronger effect on depression. And as you can see in this figure, the turquoise line represents the secondary, the newest androgens, a much higher level of depression than the orange line, which is normal hormonal therapy, and the black line is people who do not receive androgen therapy. There have been reports of suicidality also in this very large comparison sample from Sweden. Men with high risk, regionally advanced and metastatic prostate cancer were more at risk for depression and suicide than the general population. And the men who died of suicide were more likely to have been treated with androgen deprivation, be of lower socioeconomic status, and had no prior history of depression. So the conclusions of the authors were that one has to be concerned about the psychosocial burdens of patients who receive androgen deprivation. So what are some of those psychosocial burdens? So patients are emotionally volatile not only because of androgen deprivation. They also experience grief about the loss of sexual function, distress about body changes, the redistribution of fat and hair loss, distress about the lack of energy and lack of motivation, and about not fulfilling their usual masculine roles, including as a sexual partner. Clinicians tend to assume that patients do not care about sex now that they have a low desire. I know that medical oncologists would say to me, Daniela, why are you trying to treat these people, talk to them about sex? They probably prefer ice cream to sex at this point. And this is really not true, because men are very upset about this loss. And some men wanted to continue to be sexually active if they can have the ability still to have orgasms. Some want to remain engaged with their partners and continue to have sort of a masculinity protective and relationship protective engagement in a sexual intimacy. Partners can feel a variety of things depending on their own interest in sex, but some have found that they are missing it more than they thought they would. Mostly partners worry about the withdrawal, frustration, and depression in the man and the sort of loss of the usual partnership. They feel also invisible as the man is self-involved. Partners can feel the loss of the bond and feel lonely with these partners. So when it comes to treatment, from a biological point of view of depression, SSRIs can only make it worse for men because they suppress orgasm and libido. But there are medications for depression, such as bupropion, which can actually add a little bit of energy and have antidepressive properties without causing sexual dysfunction. There are very few intervention studies because this is a neglected population. The typical sexual health interventions for these patients and their partners would be grief work, sexual communication, sensate focus exercises to eroticize the body, expansion of sexual repertoire, and the use of sexual aids. A couple of studies that I can report on, somebody did a randomized controlled trial of 64 couples who exercised together, and this resulted in an increase of physical, although not sexual, intimacy on the part of the partners, although not on the part of the men. And this is important, pre-treatment education, and this is just a pilot, but 27 couples were randomized, and the ones who received the pre-treatment education that alerted them to the side effects and possible rehabilitation and maintenance of sexual activity, were in the 20% section of the, the intervention group. 21% of those patients and partners retained sexual activity versus only 4% of the control group. So education is very important. Dr. Elliott and her team developed key components for psychosocial management of these patients treated with ADT. And while I don't really have time to go through all of it, I will say the pre-treatment education is extremely important. Then a referral to appropriate psychosocial resources such as counseling, assistance with pro-erectile aids, and then discussing options for maintaining sexual intimacy, which may be a new paradigm for a couple for sexual interaction than the one they had had before, and encouragement of persistence, optimism, and emotional connectivity. Obviously, this has to be individualized. That is quite clear. I have a case to present to you of a 64-year-old man who came to me with his wife prior to treatment, very upset about losing sexual function, wanting to stay sexually intimate, and his wife, while she was reassuring to him about it not mattering since she wanted him to live, also wanted to persist if possible. So I met with them to discuss what to expect, what were options for treatment, how to maintain sexual intimacy, and how to expand sexual repertoire. And I referred him to a urology colleague for the teaching of pro-erectile treatment. 9 months later, he was done with the ADT, and also this was a patient on radiation therapy with additional ADT. His testosterone was rising, his desire was rising, and he had hopes of some, retainment of recurrence of erectile function. And they both commented how his emotionality under androgen deprivation enabled him to be much more emotionally connected to his wife. And he turned to me and said to me, "I don't want to go back to being the asshole that I was before I was on hormone therapy." And so they laughed, of course, and they clearly had an additional skill in their repertoire. So the take-home messages are, patients treated for prostate cancer with ADT can live long lives, and they do care about the impact of treatment on their sexuality and have complex feelings about it, and this should not be overlooked. Clinicians should educate patients about sexual side effects of ADT, rehabilitation, and the emotional impact before treatment, and include partners whenever possible and desirable, and then periodically inquire about sexual concerns. Both biomedical and psychosocial treatment should be available to the patient and the partner, and referral to relevant specialties should be provided as needed. And here are some resources. Thank you.